Dementia is common in older people. 11% of people 65 and older have dementia. 1 in 3 people 85 and older have dementia. So what does dementia look like, and why do we miss it in the emergency department? Mr. Manning is 67 years old and was brought to the ED by his son, who feels something isn't right with his father. He tells the triage nurse that he thinks his father has been suffering from bad headaches over the last many days. A dementia diagnosis may not be on the medical record, but an awareness that your patient may have cognitive impairment affects every step of the ED process.
Hi, Mr. Manning. Thank you for waiting. I'm Dr. Davis, and I'm going to be looking after you today.
Hello.
So your blood work looks normal, which is good. It says here that you have a headache. You look pretty good. How do you feel now?
No, I don't have a headache. Look, I'd like to go now. I have to get home to my wife.
Are you sure there's nothing else bothering you?
No, I gotta go.
Okay, well, if you think that's best, but do see your doctor this week if you still have the headache. Okay? Take care.
Dementia is often not obvious until there is significant cognitive and functional decline. In the ED, we are with patients only briefly, and if we don't take a bit more time to get a complete history, we can miss dementia entirely with potentially serious results.
Hey, where's my dad?
Oh, your dad left to go home.
What? You let him go? He wouldn't know how to get home. My father has dementia. I just have to go get my kids. How could this even happen?
Mr. Manning is found an hour later wandering by the side of the road. His family lodges a formal complaint. What if we took 30 seconds longer with this patient?
Hi, Mr. Manning. So your blood work came back normal, which is good. It says here that you have a headache. You look pretty good. How are you feeling now?
No, I don't have a headache. Look, I'd like to go now. I have to get home to my wife.
Okay, I was wondering, can you tell me how you got here today?
How I got where?
Can you tell me what the date is today?
February 15th?
Actually, it's June 20th. It looks like you're having a little bit of trouble there. I'd like to call your son. I'm sure he'd like to hear from me.
Yeah, that sounds good.
Ask something kind, casual, but recent, requiring short-term recall. This may shine a light on potential underlying cognitive impairment. And once we have identified potential cognitive impairment, connecting with a family member or caregiver is essential to obtain a collateral history.
Let's put this on speaker. Hello?
Hello?
Hi, is this Clint Manning?
Yes, it is.
Remember, dementia is common and may not be on the medical record. Ask questions that require short-term recall to check for signs of cognitive impairment. Involve family members or caregivers to gain collateral history. What if we know our patient has dementia? What adjustments should we make? Let's see what might not work so well with a usual ED approach. Julian Richards is an 80-year-old man living with dementia. His wife brought him into the emergency department because he hasn't been eating, and she feels something is not right.
Hi, I'm Dr. Duncan. Are you Mr. Richards? Can you tell me what's been going on?
People with dementia may have difficulty answering vague questions or questions of episodic memory.
You know, Julian is having problems describing what's bothering him because of his memory issues, but I really think there's something the matter. He's not eating. Maybe he's in pain. You can see something's not right.
Feeling a little discomfort, hon? Maybe a little pain in the belly?
People with dementia understand tone and nonverbal cues. Avoid patronizing speech or elder speak.
So how long has this been going on?
Well, it started beginning of the week. He was
Examining a patient without their consent is never appropriate.
Well, he does seem to be in some discomfort. We're going to need a CT scan and some blood work to see what's going on.
The results of Julian's tests show he is dehydrated and has complicated diverticulitis. The doctor determines he should remain in the ED overnight to receive antibiotics and fluids.
Oh, well, if he has to stay, can I stay with him? He doesn't do good on his own.
We don't let visitors stay in the ED. You should go home and get a good rest. He'll be fine here. We'll take good care of him.
Caregivers are not visitors. They are an essential part of the patient's care team. A few hours into his stay, Julian became agitated due to his abdominal pain and being in a loud and unfamiliar environment. The next morning, Olivia returned to find her husband sedated and restrained. Along the way, we saw many opportunities to change our approach and do better. Let's see what that would look like.
Hi, I'm Dr. Duncan. Are you Mr. Richards?
Allow time for the patient to respond.
I'm okay. I'm okay.
Julian has problems describing what's bothering him because of his memory loss. But I think there's something really the matter. He's not eating. Maybe he's in pain. You can see something's just not right.
Thank you for telling me that. It's important that I hear from the both of you. Julian, are you feeling any pain right now?
People with dementia are often able to answer questions of working memory, such as what they are feeling right now. Ask simple, short questions in a positive tone of voice.
Yes.
And where is the pain?
Here. My stomach.
I'd like to examine your stomach to see what's going on. Is it okay if I touch your abdomen?
Take the time to explain what you will do to examine the patient and obtain their consent.
Dr. Samuels, room 312, Dr. Samuels.
Thank you, Mr. Richards. Would it be okay if I asked your wife some questions too?
Yes.
Involve the patient. Ask them before addressing the caregiver.
What else have you noticed? I see here he's not eating.
When your patient has cognitive impairment, a collateral history is essential.
Well, it's the not eating that confirmed it for me. That started the beginning of the week. He's been pushing food away and getting a little bit upset. And I didn't know why, but now I think it's because he's unwell. He can't always tell me what's going on because of the dementia. So I just have to go on what I see.
I see. Julian, I am concerned about your pain. We'll need a CT scan and some blood work to see what's going on.
With some small changes in our approach and communication, the patient and caregiver have had a much better experience. The doctor returns with the test results and lets them know that Julian will have to stay the night.
Do you think you or a family member can stay with him here for some part of the night?
Oh, yes, I can stay. Is that allowed?
Yes. You're providing important care. You'll be welcome to stay at his bedside.
Caregivers are an essential part of the patient's care team. The staff asked Julian and Olivia to fill out a "This is me" sheet, providing important background details that Julian might not be able to offer if Olivia was out of the room. That night, Olivia notified the nurses when Julian started to show signs of discomfort. The nurses used the pain ad scale to determine when he needed pain medication. Olivia was able to keep him distracted with talk about the kids in the old days. Remember, dementia is common in older people, but not always on the medical record. Questions requiring short-term recall may alert you to potential underlying cognitive impairment. When examining a patient with cognitive impairment, respect the patient and engage them directly. Never use elder speak. Ask questions about here and now. Engage caregivers for collateral history. Be proactive about assessing comfort and care needs. Know that agitation may be a means of communicating needs. And always remember, caregivers are not visitors.